morning, good afternoon to one and all. Today, my paper is bringing virtual reality to real world, comparing VR perimetry with standard automated perimetry. Glaucoma-related blindness is estimated to increase to 112 million by the year 2040. If you look at the prevalence of undetected glaucoma, there are 44 million cases globally, out of which 77% of them are estimated to be prevalent in low HDI countries of Asia and Africa. These numbers stress that we need to strengthen our screening strategies. Standard automated perimetry has remained gold standard for glaucoma screening. However, it has its own drawbacks, like bulky setup, requiring dark room, and poor patient attention. Evolution of technique is definitely the need of the hour. In this study, we have used Smart System Virtual Reality headset. It comes with an SSVR headset and a hand trigger by which the patient gives the response, and this is paired with a Microsoft tab. Our study objectives were to analyze the sensitivity and specificity of this novel SSVR headset perimetry compared to standard one, to assess the performance in mild, moderate, and severe glaucoma groups, and also to look at the patient feedback about both these techniques. We included all the glaucoma patients aged between 80 to 70 years with best corrected visual acuity of 618 or better, and who were able to perform visual fields reliably. We excluded all those who had undergone surgery in the recent past, and extremes of refractive error, plus or minus 5 diopter, were also excluded. Controls were also belonging to the same age group who were able to perform visual fields reliably without any media opacities which could bias the diagnosis. Coming to methodology, we had 362 eyes of 222 patients in cases and 151 eyes in the control group. Baseline ocular examination was performed as shown in the image. These patients were subjected to undergo standard automated perimetry and VR perimetry in random order with a 10-minute resting period on the same day. Patient feedback was obtained at the end of the procedure. Coming to the results, glaucoma patients were found to be older as compared to controls. If you look at the mild group here, we had 160 eyes. We found that fixation losses and false negatives were significantly lower in the VR perimetry group. False positives were found to be higher, and test duration was in fact found to be longer in the VR perimetry group. We saw the similar trend in the moderate glaucoma group as well. In this group, we had 103 patients. In the severe glaucoma group, we had 99 patients. Again, there was a trend of lesser fixation losses and false negatives. In addition, there were significantly better threshold sensitivity in the VR perimetry group when it came to severe glaucoma. These were some certain samples which is obtained from standard automated perimetry and VR perimetry. This is moderate glaucoma and this is severe glaucoma. This VR headset is testing 60 points in 4 quadrants, and in addition there are 4 central points closer to fixation. This is the ROC curve analysis which showed that the 24-2 Z strategy was a good technique, especially in estimating mild and severe glaucoma. We also did a scatter plot analysis to look at the mean deviation values of VR perimetry versus standard automated perimetry, and there was a very good correlation. The bland Altman plot showed that majority of the readings were within the 95% confidence interval range. When we look at the patient feedback, 66% of them felt that the VR perimetry was easier to perform. 40% of them felt that it was ergonomically more comfortable, and 38%, if at all given a choice, wanted to go with VR perimetry as compared to 53% who gave an equivocal response. Ocular discomfort was slightly higher in the HFA group. Coming to discussion, this prototype of CFA device this CFA device was used, and here supra-threshold strategy was utilized. The ROC curve here was higher for the severe glaucoma group as compared to moderate and severe. This is another study where Gear Vision headset was used, and here the fixation losses was much higher as in contrast to our study. The false positive response rates were higher. Threshold sensitivities with Gear Vision was significantly higher than that with HFA, and this was in fact attributed to the non-occlusion of the fellow eye, which is in fact a more physiological way of testing visual fields. VR perimetry is in the market for quite some time now, so what new thing are we bringing to the table? This is a prospective study, and to best of our knowledge has the largest sample study recruited so far. There is real-time tracking of patients' performance. Z strategy is being utilized, and we can see that there is definite evolution of technology, which started off as a supra-threshold yes or no, pass or fail test, has become very much comparable to standard automated perimetry. What were the drawbacks which we saw? Time taken to complete was slightly longer because the VR perimetry was pausing the test until the patient regains the fixation. There was no clear superiority of VR perimetry over standard automated perimetry. Now, what is my take-home message? VR perimetry should be used as an effective bridging tool to strengthen glaucoma screening, especially in crowded OPDs, in outreach and vision center settings, targeting high-risk patients, and also in using home screening for vulnerable patients. Thank you.
Thank you. See, the only concern in this, from this study, which comes to my mind is that there are a lot of false positives in the VR study.
Yes, sir.
And false positives, although when we technically say, the machine says that they are taken as equivalent to false negative, but in the practical sense, false positive are far more important than false negatives or even fixation losses.
Correct, sir.
So that makes this instrument much less reliable to me from your study.
Yes, sir. The reason for this is the technique by which the machine is estimated the false positive, sir. The machine is, the way the Humphreys is estimating is slightly different. So there is yes or no test. But here, what the device or VR headset is doing is that if at all the patient is responding very quickly, if the minimum response time is very fast, that way it is counting it as a false positive. So basically,
so do you think the false positives coming in this machine are less significant than the false positives coming in Humphrey field? Do you mean that?
the other way of saying it is this machine is very sensitive to patients' false positive responses. So that should be worked upon before we bring it to the market, definitely. I agree, sir.
You said it takes more time.
Yes, sir.
And you also said it can be used for screening.
Yes, sir.
So how does that call?
The reason why this was taking longer time was the VR headset.
No, I understand. I understand that.
It is pausing the test in between, sir.
No.
whenever there is fixation.
When a screening test should be
Faster.
faster.
Agreed.
So
Agreed.
how can
Then
One
how
more
are we
thing is-
monitoring the gaze tracking? How are we doing the gaze tracking in this?
Gaze tracking with the CCTV, it can see how the patient is moving the eyes, and it can fall with the.
So we need somebody to monitor even on this device.
Yes, madam. The tab which is there can monitor the patient's performance in real time.